danser, yeah. Big County Big Collection. Danser, yeah. Big County Big Collection. Danser, yeah. Big County Big Collection. Danser, yeah. Big County Big Collection.
Ladies and gentlemen, we'll start in about 1 minute from now.
Okay.
Thank you.
Big up, Paul. Thanks for joining in. We're going to be starting very soon, please. Hope you guys loving the tunes.
At the vitamins in the pineapples.
Well. Good evening, ladies and gentlemen. Welcome to another edition of Health Talk, the Alafia show, the Wellbody show. Ladies and gentlemen, it is another edition of Eternal Production Wellbody show. We no one give the show any particular name. This show, it's about health precautions, health advices, health interactions, all things health and all things Wellbody. My name is Bumike Smythe, and I will be one of you moderators today. But with me, I get somebody we don't do this since the start of the year, and I go like for welcome Mrs. Rachel Bania to the show.
Yeah, thank you, Bumike. Thank you, and welcome everyone to another edition of the Alafia show, the Wellbody show. As usual, we're all happy to be here, and we're glad that you're not able to join me back today for hopefully another fantastic show where we all will take a lot from in terms of health, which is wealth. So, Bumike, I know today's show is mainly about the men, so I'm going to leave the bulk of the talking to you.
Well, since we start about just a few minutes later, I'll say about 15 minutes over which we've been scheduled for beginning, we'll go dive right into what we Kaya for do today. Today, ladies and gentlemen, we can't talk about prostate cancer, and I hope say we man them we go text we paddy them, we go text, we family member them, the woman them. On our self text, husbands, significant others, boyfriends, brothers, whatever on our text, because you know, some of the things we're about for land today, it could just open we eye and it could just lead we for make better health and lifestyle choices. Before we continue, before I introduce the very first doctor, we last presenter today, in name na Isata Sise Jalo. Now I mean supposed for round up the program for we today, but unfortunately it just get a family emergency. So una let we keep her in with prayers and let we hope say whatever they deal with, the man where they upstairs go look out for him and look out for his family. Una thank you for understanding. The very first doctor I'm gonna call on, if I don't follow the show, na Dr. Akpan Spencer. In credentials, then at the screen, I no need for read them out to una. But as the weeks they go by, I can proudly tell una say, he's an Arsenal fan, so he really don't the cack by himself lately. So if we do the program, una see get extra swag today. Now because for the first time in like almost 20 years, by Christmas Day this year, Arsenal go there on top of the league. So let we allow him, and it can share some valuable information with we about prostate and prostate cancer.
Yep.
Yeah, thanks, Veronica. Move the slide on, please. Yeah, fabulous. Right, okay, so prostate cancer. And, you know, as the name is self-explanatory, you get prostate gland, you get this, within this blue circle is where ideally your prostate gland is. And in the middle of the prostate gland, now from there, your urethra, they begin where urine they pass from your bladder go out. So now the cancer they form. And one of the jobs of the prostate gland now for produce seminal fluid where they nourish and transport the sperm cells. So go on to the next slide, please. Right, okay, so basically I've just put together different images of the prostate gland. On the one we now picture with labels, nana drawing, and you see the prostate walnut shaped size. You get your seminal vesicles when they the sperm cells, then they be stored, and then during ejaculation, as then they pass through your prostate, you get the seminal fluid as well, and all common ado. And then the middle column, you get a CT scan, and if you're able for make the comparison, compare the diagram with the CT scan, if you're able for suicide the prostate gland. I don't have control of the screen, but yeah, if you're able for suicide the prostate gland, so you get what we call the sagittal plane and you get the axial plane. And then the next column, you get an MR scan. Now you see the difference with the MRI scan, you get a lot more detail of the actual composition of the prostate gland. And this is why, in terms of diagnosing prostate cancer, the MRI scan is far superior because you get a lot more detail. Thank you. So move on to the next slide, please. So this leads on to the question, wetin dey cause prostate cancer? So far, we don't have a concrete answer to this question. You get so many different hypotheses and potential risk factors. There's genetics plays a role. You get the theory of the prostate stagnation theory. Yeah, but today, with all the advances in medical science and this nothing where people then steal the research. We're not able to pinpoint waiting they cause them. But as with all cancers, something they trigger the cells at the prostate gland for begin reproduce and multiply uncontrollably. And that's basically what happens. So next slide, please. Now, obviously, prostate gland, now man no more gets prostate. So it affects men. Generally, they say about 1 in 9 men will be diagnosed in their lifetime. And about 60% of this diagnosis in men above 65 years. Now, in the UK, it's the most common cancer in men. And apparently every 45 minutes, a man dies from prostate cancer, with about 12,000 men every year. Now, in Africa, it says the leading cause of cancer in sub-Saharan African men. But again, data limited. So expanding on this a bit more, move on to the next slide, please. As you grow older, your chances of getting prostate cancer increases because it's technically an old person's disease. Now, as you see the numbers, 1 in 350 men will be diagnosed below 50 years. 1 in 52 diagnosed between 50 and 59, and then about 60% of men greater than 65 years. Now, this based on data available in Europe, in the Western world, there's the thought that African-American, Black men get greater or higher incidence, and then they suffer with much more aggressive forms of prostate cancer than their white counterparts. However, interestingly, Black men in the US and Europe have a 40% higher incidence than men in Africa. Now, that could be a combination of factors. Either we know they make the diagnosis properly in Africa, limited data, and whether or not environmental factors, etc., play a role. Now, the whole thing about Black people having much more higher incidence and more aggressive forms in the developed countries could also potentially be explained by the disparity in access to healthcare, because we all know the effect of racial inequalities, etc., and how that they filter down in virtually every facet of our life. And so Black people generally in the West, there's the belief that potentially this long-standing view that prostate cancer much more aggressive in Black men is because we don't present to our doctors early. If we do have doctors or insurance, depending on where in the world you are, we don't go early. We go sit down the beer with the symptom them until it's a bit too late. So by the time we'll go to doctor, the cancer don't spread everywhere. So move on to the next slide, please. So moving on to risk factors. Now, we've divided this into what we call non-modifiable. The thing that we're not in the way you can do about them. I.e., we all get older. That's a fact. So you can't change that. Your ethnicity, again, this whole thing about Black men and increased incidence and aggressive forms of cancer. Genetics, family history. So then they put you as a higher risk. So if you are a 70, 75 years old Black man with a family history of prostate cancer, you risk exponentially greater than, your counterpart white person. And then you get the modifiable risk factors where, poor diet, lots of saturated fats, red meat, and then being obese. Again, if you remember the very first programs that we had, we talked about exercise and weight control, and these things have an effect on so many different forms, so many different types of diseases. Too much consumption of alcohol, again, smoking cigarettes, all that thing, and then the one are the modifiable risk factors where you can change your lifestyle, you can change your habits, and potentially might have an effect or reduce your risk. Right, now, this part, I decided to talk about this separately because based on the whole prostate stagnation theory that, if you've got your seminal fluid and it's not being released or ejaculated, this potentially could lead to buildup of toxins, etc., which might activate or cause your cells to start dividing. Now, fact or fiction, we don't know. We've got conflicting results. There have been studies that have said that studies will say it has an effect and it reduces your risk. There are other studies that say there's no correlation between your frequency of ejaculation and your risk of prostate cancer. But then if we move on to the next slide now, I basically put this particular study and I give the reference for this, because for me, this study was probably the most detailed. And what they did in the US in 1986, they enrolled over 51,000 male health professionals into an epidemiological study, where then they look at so many different health conditions. And these people have been followed up over time from 1986. Now, and the age of these healthcare professionals, about 40 to 75 years. And of that 51,000, almost 32,000 of them were included in this study on ejaculation frequency. And this was based on a questionnaire that they were given in 1992. Now, where to make this study stand out to me, the fact that, one, when they asked the men the question, they're not asked them how then they ejaculate. So there was no distinction whether or not it was masturbation or sex. And so that in a way kind of reduce maybe the embarrassment where some man go feel for answer the question and potentially make them answer a bit more truthfully. Secondly, this was a prospective thing. So this question was asked before the men had been diagnosed of prostate cancer. And that's different from a lot of the other studies that show no benefit, because a lot of those studies, the men have already been diagnosed with prostate cancer. And then they ask them, okay, what was your ejaculation frequency like at, this particular time in your life, etc. Whereas in this case, this question had been asked. And then 2 years later, I think when PSA came into mainstream, they were then subsequently asked about their PSA results. And based on those PSA results, those were documented and then followed them up over time. And so the question as well was how many ejaculations on average you had a month during the age of 20 to 25, and then, 20 to 29, and then 40 to 49, and then in the year preceding the year just before the questionnaire was given, so in 1991. And then what this study showed, if we move on, to the next slide. What this study showed, so in 1994, when PSA level was mainstream and people were having PSAs, they were asked questions about their PSA level, if they'd had a prostate biopsy and a rectal ultrasound scan, and what the results were. Now, for the one then we then get diagnosis of prostate cancer, they then went back through their medical records and then, retrieve information about the stage of the cancer, how it was diagnosed, how aggressive it is, etc., etc. And these patients were then followed up from 1992 all the way to 2010. So, and they were given follow-up questionnaires every 2 years, basically finding out again, how then they progress through their treatment, etc., etc. And what the study found was that men who reported an ejaculation frequency of 21 or more every month at between 20 and 29 years and 40 and 49 years had a lower incidence of prostate cancer compared to men who ejaculated about 8 times a month. Now, that was statistically significant. And again, you know, I know some, especially women, might not want to believe, but if you look at the authors of the paper, right, of all the authors, if you now look the name them, now one game post in a man, all the other one they now man. So no two man cook up the data and the information for, you know, for promote greater ejaculation frequency. So this was a scientific study that was carried out. Now, again, other studies have tried to, well, I'm not sure if there's been other published studies that have tried to replicate this, but other studies where the sample size were much smaller and were not as detailed and did not get this long period of follow-up, not able to replicate this result. So moving on, please.
Bumike?
Right, okay, so.
Okay, so Dr. Akpan, thank you very, very much. We next guest. Now,
but Rachel, before we get to the next guest, I just get a couple of things for tell Dr. Spencer.
Okay.
I'm not too glad with Dr. Spencer because last month we do breast cancer. It debunked one myth we not go in with the man in favor. The way how the thing they go this month again, I was all excited, say, you know, some of them thing there are true again. It's not simple to go, and this is turning out to be a trend. But you know, a lot of
okay. So my position on this, right, is
what exactly you're not happy with?
Let the doctor talk. Just set him up. Thank you very much.
So, right, my position on this is straightforward. Nobody has proved beyond any doubt that ejaculation frequency does not reduce your risk. Okay, and you have, like I said, this particular detailed research which shows there is a benefit or there's a reduction in your risk for prostate cancer when you have, on average, about 21 ejaculations a month from basically your lifetime, well, up until a certain age.
21 a month?
Yes.
Oh.
21 a month. Now, so my position, right, now the caveat is, and I think this is my own position. Now, all man free for do what you want, all man free for believe what you want. But my own position is it doesn't hurt, right? So me go advocate as many ejaculations as possible. That's my own position, because at the end of the day, if it's been shown that there is a benefit, despite the fact that some people might say, no, there's no benefit, but nobody knows show me categorically yet say non-benefits no exist. So if I don't get detailed paper like this where shows say benefits day, I prefer for believe that day.
Okay.
Yeah.
Thank you for that. I mean, me at Scott, I'm just saying at 21 a day we talk, but I'm glad you don't clarify.
Well, I actually feel much better because now we've actually Naomi they text me on the side and Naomi while I pass this information on to you. So
sure.
There you have
it. Sure.
Over to you, Rachel.
Let me on the good DJ. Anyway.
Of course.
Anyway, I told you guys this is gonna be a very interesting one. So just left the man there, let her just deal with all this. So we next guest, Dr. Innocent Moniatambi. Now, well, it's an internal medicine specialist and a primary care physician. He graduated from Howard University School of Medicine and has over 18 years of medical and research experience. He's a member of the board of directors of Tongo International Solutions, a nonprofit organization with a mission to provide access to opportunity, healthcare, innovative farming to alleviate poverty and promote positive social change, sustainable progress, and social justice for the citizens of Tongo Field in the eastern provinces of Sierra Leone. So without further ado, Agolek Flo, we all welcome Dr. Monia Tambi to the show. Dr. Monia Tambi, thank you for joining us. We're honored, we're privileged. Over to you, sir.
Dr.
Okay.
Tambi, welcome, welcome, welcome.
All right, thank you very much. Thank you. So I think the next screen now about prostate screening. So basically from what you go see from the screen, it's, I will take on this way. There is what we go call a non-specific guidelines on screening, meaning, and I'm sure what you do in the US, now probably the similar thing in America and European countries, we get certain guidelines so they can be, and everybody supposed for kind of go along with those guidelines. But personally, what to me they do different from the guidelines. So I'm glad the way, the statements are very controversial for prostate cancer. PSA is the most common screening tool, but the PSA itself, all by itself, it now really get a lot of detailed information because sometimes it can be a little bit high, not necessarily mean cancer. And then the question becomes, do you want to subject that individual to further more studies? You want to deal with the anxiety and so many other issues, the test, the cost, all the other things will come with the many tests. But the fact is, in America, the recommendation is to discuss with your provider. So, patient come, we talk to them. If they're of certain age, and I will come to that age day, then you go talk to them for say, okay, we need for check PSA, we need for do this. Now, they say there's no evidence that it reduces the number of deaths from prostate cancer. That's what they say. But that one person in that family will go end up forgetting prostate cancer. It's a significant thing. He's a father, he's an uncle, he's a grandfather. So the question becomes, are you going to go with the guidelines or you go with what we can call the humanitarian approach? Okay. So all these evidence sensitive but not specific, leading to increased investigation and over-treatment is all true. But me can say from me on approach, I do the PSA starting at a younger age for Black people compared to white people. And let's go to the next screen, please.
About 1 minute.
Sorry?
No, nobody
Oh,
does
okay. Okay. So, United Kingdom, no prostate cancer screening. In the United States, discussed with primary care, non-Blacks advised PSA test for 50 years, Black 45 years, Black men at high risk PSA from 40 years. So, okay, so the first bullet point, there, non-Blacks advised PSA starting from 50 years. I'll take that for be the general acceptable approach. Because, as Dr. Spencer pointed out, the incidence in Black people from Africa and those in the diaspora is very high. And so for Black men, the PSA test around 54. But the other thing we can add to some Black people, and I don't begin to talk a lot to when I say young Black people, I mean below 50 years. Now the digital rectal exam. I don't know how many man in there. I know it's uncomfortable, but again, and I will tell you why I can tell them say I did one. The reason being, just like the PSA, it's not 100% accurate. And even when you do the digital rectal exam, depending on whose side you examine, you may not get the full answer. And so generally, any Black man below the age of 50, but above 40, you see me point, and I'll say 40 specifically because I can say 42 from there up to 50 or going above. I can encourage them, if they allow me, would they do the PSA, and at the same time, I want to do the digital rectal exam. I don't know if there's a slide we talk detail about digital rectal exam. Dr. Spencer, any slide we talk about digital rectal? I know I mentioned something.
I think that might come under diagnosis.
Okay, good.
Not so much screening.
Yes, so for me, but if somebody there above 50, I do both. Okay, you might not get all, but you might get some information what will give you a clue that something is going on with the prostate. So Black men, I can encourage them between the age of maybe 42 to 50, they allow me, of course, PSA a big one. Then if they allow me, digital rectal exam. And obviously, the PSA at high risk wouldn't be top there, Black men at high risk, meaning if they get any family member, we get a certain type of breast cancer, genetically proven, the BRCA1 and the BRCA2. I can intend for discourse with them. So if they say, oh, first degree relative, my sister, my mama, you know, then can people then get breast cancer? And they put them in that category as high risk. There's another disease we can cause colorectal cancer, what they call Lynch syndrome. If they get people like that in their family, and they encourage them for get earlier screening. So the risk factors, you know, those are the ones who may consider risk factors. Okay, I will try for tell them above the age of 40. I tell them, say, listen, the guideline says this, but for my own conscience, for let I help you, low down. There was a 45-year-old guy where I do he say he feel very uncomfortable doing what I do. He say he feel invaded, but you know the point is it's to help the patient. Okay, so those categories would then put good. So let's go to the next slide. Okay, the signs and symptoms. Unfortunately, as the slide states, it's not easy for individuals then just attribute symptoms to prostate cancer, and not easy for some individuals. Then it's also not easy as a physician or patient to talk to you for they just think that this sign here would be due to prostate cancer. I'll give you one example. A patient, this was maybe 3 or 4 years ago, in his 60s, but they talked to me, say the cough. Obviously, but not a smoke, so you're not being a risk factor, but still, you know, the cough, I don't know why. Now I say, well, you know, because of all this complaint, at the second time this you don't call, they talk about cough, they'll do x-ray. Interestingly, it was a metastatic prostate cancer to the lung. So even for the physician, sometimes it's so confusing. Now, if a 42-year-old man, they tell me, say, hey, boss, you know, I can get some Viagra. They ask you why. Say, well, I did get some kind of things, you know, I did get some erectile dysfunction. I can say, well, you know, before we do that, let we just check both the PSA and let we do a digital rectal exam. If somebody say, well, you know, doc, there was a guy, very good, 45-year-old from Africa. It be the pee a lot, but at the same time, it say, anyway, if you don't begin smoke marijuana, I don't know why we take old before you begin smoke marijuana. So in wife not been like that, so in wife talk to me. So in the feeling and wife they sabotage for no stop and for the smoke marijuana. But really be the pee a lot. Again, so that I say, well, it's not too normal, given in health women or history where I know. I say, so now do everything. And surprisingly, in PSA being high. Now, I don't the observer, I think this will be 6 or 7 years. I've even sent out to oncologists at one time, but they're not prove yet. Well, they're not prove say you get prostate. I don't anticipate say you will get it. They're not proof, but in PSA was hard. So it's so difficult sometimes because some of the symptoms that people don't will tell you are things the way they see in other people. You know, trouble urinating, decrease in flow, then incontinence as well. Okay, blood in the urine or the semen. You know, those things, a lot of things can cause them kind of thing. So it's not easy for you just think of prostate cancer because these are common not only in prostate cancer but in other diseases as well. Now, low back pain, it's as well the same thing. It's a issue because it's a 72-year-old man a few days ago. They tell me about in back pain, low back pain. Now, so really what I ask in detail, I found out that the back pain don't go on for long. Unfortunately, this now the second time I see this man, the first time that'll be a brief encounter. So now I just tell them, say, well, you know what? I don't feel comfortable. They just tell me half and half information. You want to help you. Can't see me as a patient completely. The reason he talked to me because in Sierra Leone it happened for dinner at the hospital. So now I say, can't see me as a patient. I do a complete history, get more information. So really, I mean, they think, say, what if this guy had a prostate cancer? Well, we can think of so many things, spinal stenosis, but again, this back pain we need for investigator because I'm not going to meet another person who don't get metastatic prostate cancer, okay? And that back pain can be in people usually who have metastatic disease, fever and weight loss, that people will get higher stage of the disease as well, okay? Let's go to the next slide. Okay, I talk about urinary incontinence, bowel incontinence, erectile dysfunction, numbness in the legs, the one that they usually, now most where I don't see it. Again, therefore be very careful what they talk. It doesn't mean there's exclusivity of symptoms in a patient or an age group. So numbness in legs usually of anything and then a metastatic disease, but it doesn't mean it not going to happen in other stages, you know, lower stages. And actually, this is a good statement. Having symptoms alone do not indicate prostate cancer, as many symptoms are standard with the aging process. If you do notice this, please see your doctor. I think that amount you try for do, hopefully we'll get something done. Let's see. Okay. How do I lower my risk? The way I see a healthy lifestyle, not ever go wrong in any situation. Never. So there might be, you know, people that individual nuances, you know, but of course, low-fat diet, fruits and vegetables, you know, less of dairy products is a little bit controversial because a lot of people can't do without that. And actually, I think it was last week or so, I did read about the food component, the way research at one point don't prove say beneficial for prevent prostate cancer. A few years back, some people then do some studies, they say, oh no, so you get these conflicting things, but you can never go wrong with a healthy diet. Now, the greatest culprit when we talk about healthy diet now, the greatest culprit for cause problems, high fat diet, of course. And most times I read one point at one time say red meat, you know, get for maintain a healthy weight, not just for prostate cancer, but for many other disease processes. Of course, smoking, we all know say smoking not just cause lung cancer, but it cause it get a lot of carcinogens inside cigarettes. Exercise most days of the week, so that's good. Let's go to the next slide. Okay. Early detection. So the two way me like now both the antigen, the prostate specific antigen and the digital rectal exam. So the PSA, we don't get a clue, then go for the checkup and see where the progress. Sometimes you can check a PSA this year and next year is a big difference. For me, that's significant. In some people, that's not too significant. And so you go, but the digital rectal exam, which make a letter, there was a patient, I think it was 2018 or 19. I been examining the year before, just by PSA, because number one, do the digital rectal, you know, most people know letter for some reason. So he agreed for letter. So where I do the exam, the prostate been get some nodules, and it been get characteristic would make me very suspicious. So I tell her and say, well, low prepare reminds them because low follow up with the PSA. Of course, when the PSA count was more than 200. So that straight away give me a clue that something is going on, because the following year it was probably like 6 or 7. I don't know, but it was a big difference. Whatever the difference was, it was significant. Of course, where I sent on prostate cancer, I didn't get, and it had metastasized. But just imagine, so that man probably don't get the year, either the year before or the year where I do the PSA only, and just look in the space of 1 year, what happened. So who knows when it really starts? Again, so now, unfortunately, and this is the truth, when you do the digital rectal exam, because you feel on the sides and the posterior aspect of the prostate, you may miss if the nodules then they're on the anterior part. And so in those cases, MRI, Dr. Spencer says the best, you know, almost times where they in doubt, they say, listen, let's just involve oncology team first. If whatever recommendation then you go with them. Because sometimes also, remember the biopsy, the samples that they take, they might miss. That's why they take so many samples for data. Now, one man complained to me, but in a joke, that the worst way women make ever undergo another biopsy where you go through. But you know, he was 67 years old, so I don't think a choice. You know, but they be safe for follow-up, you know, because of the characteristics of the tissue we didn't get. So this basically the trial talk about imaging, MRIs right there, and then biopsy. So that's really how then the diagnosis. But the man then get for be willing for be uncomfortable. That's just the message. That's the most important thing. I don't see anything wrong with digital rectal exam. You just get for make a open your mind, say, listen, man, just do it. If it's going to save me, let's do it. I think the next slide is then Dr. Spencer.
Well, Dr. Tambi, Innocent, thank you very much.
Welcome.
There's so much to unpack, but I hope say the audience then they take notes, and you know, we'll go do a question and answer session at the end. And you know, this is very interesting, because so many things we take for granted, and so many things we feel saying are one thing, but it's another thing. So even you as the medical professional, you know, the way you put onto we, you know, I think one, we get for willing for go to the doctor first, because we just knock in one go. And two, now you don't add a second layer where we go, we have to be willing to be uncomfortable. So I hope the men are listening, because you know, it's a clarion call. Some of we are getting up there in age. Not me particularly, because I'm still young and youthful, but me president on the old. So you know, thank you very much, and I just hope this is a word to the wise. But we move right along at the program, and Dr. Spencer will come back inside. right?
Yeah. Interesting, in the sense, the case example that you gave about the man with being the cough, and it turned out it was metastatic prostate cancer, because I some years ago I ended up they present some case in a Canadian Association of Nuclear Medicine annual conference, which was patients will come for a nuclear medicine test, FDG PET CT, and it was basically for lung cancer. He had a lung tumor and he had lymph nodes. Now, when he went for surgery to take out the lung cancer, then decided for take out the lymph nodes as well, because, you know, they weren't very active, but they thought, you know, be on the safe side. And when they looked at them under the microscope, the lung nodule was lung cancer. The lymph nodes were prostate cancer. And it turned out that this gentleman had prostate cancer about 10 years prior. And he'd had his prostatectomy. And this was a recurrence, which ended up in his chest, as opposed to near where the prostate bed was. So yeah, it was an unusual case. But anyway, so moving on to my own area, you know, I'll not say I like picture them, so I can show now some picture them. I don't know if they see me mouse.
Yes.
They see me mouse. Good.
Yeah.
So right now, this I'll start first with a benign case. So one of the two things where the main thing where they affect prostate now, benign prostate hypertrophy, BPH, where Nadandin at the first thing where plenty man go begin struggle with difficulty passing urine, etc. And this is not a case of BPH. And I show them because you see on this one, the sagittal view, that's your bladder. That's the prostate gland, and it's big to the point that it obstructs urine flow from the bladder. So now then kind people here go to struggle for wet, or whenever they go wet, then feel like, say, you know, something still left in the bladder. Anyway, so that's an enlarged prostate. But in his case, it wasn't cancer. And if you look the anatomy as well, one of the reasons why we do rectal examination for detect prostate, that's your prostate, that's your rectum, right behind it. So you're able to feel and get an idea about the texture of the prostate gland, etc. Now, so next slide, this is MRI scan. This is the gold standard for imaging investigation of the prostate gland. And the beauty about the MRI scan is it shows you a lot more what we call soft tissue contrast. It's got much greater contrast resolution than, yeah.
Hey, I'm not sure that your screen changed.
Okay.
Yeah.
Can you go into slide? Okay, could you enable editing at the top where it says enable editing? Can you click on that?
Where is it? I can't see
At the top.
editing.
At the top
So
of the picture.
You might be sharing, you might be seeing the, are you seeing the whole slide as a presenting mode?
Yes.
Okay, then look at your taskbar. You probably have two PowerPoint showing, but what we are actually seeing is your slide deck and not the slideshow itself.
Right. Okay. Let me stop first of all.
Yeah.
Right.
Hey, Akpan, if you get problems, just call you Pekin.
I know. You know, I go answer you back. No worry, wait.
Okay, so now I think I see your mouse moving. Right. So click on enable editing.
Where is it?
Over the
Right
top.
above the mask. The
gold bar or the yellow bar.
Yeah.
Oh, right.
Yes, yeah.
So click on that.
Yeah.
Oh, hold on one second. Let me, one thing.
So do I screen share now?
Yes, go ahead.
Okay. Right.
All right. Here we go.
Can you, okay. Right. So I can see it now. Okay, fine. I'll start again. Well, no, I'll just show this first slide was basically a benign prostate. So on this is your MRI scan. And I do see now all in the move.
Yes, we see now.
Okay, right. So that's the MRI scan. And this patient has prostate cancer. Now, on the MRI scan, you can see the prostate, you have your central and transition zone, and then you have your peripheral zone. Prostate cancers generally start in the peripheral zone. And so there's been studies that looked at men who have BPH, whether or not prostate size has any link with prostate cancer. And one of the things that we then found that if you get big prostate, not necessarily means say you go get prostate cancer, because BPH, the enlargement starts centrally from the central and transition zone. And because now they enlarge and they expand, they compress the peripheral zone where they induce, fibrosis, etc., and where they make more difficult for cancer for develop. So people generally with normal prostate glands tend to be the ones who are at higher risk of developing prostate cancer. And so in this case, you see this dark area is the cancer in the peripheral zone. And this is like your axial image, and this is a coronal image. And this area as well, that's the prostate cancer. And you see it's from outside, because as it gets bigger, it compresses the central zone of the prostate. And then with this, it's all confined within the actual prostate gland, because the gland has a fibrous capsule. So in this, it's like a local lower stage disease, even though the cancer actually big, but breach the capsulate. So for this one, potentially curative treatment can be prostatectomy. But yeah, so that's what it looks like on the MR. And the gold standard really for MR investigation of prostate is called multi-parametric, because I'll try not to get too technical, but with the MRI scan, you have different sequences that they do, which show different things better than other sequences. So in addition to this sort of image, you get what's called the diffusion weighted sequences, which the diffusion weighted sequences, and you get the one that where then they give contrast, where they make it light up more. So the combination of all the changes, then they on all the different sequences, they increase the sensitivity for make you say with certainty, okay, this not cancer or this not to cancer. So moving on to the next case now. This is a locally advanced disease, because if you remember the previous slide, look at the prostate on this one, and you see what it look like. Very irregular. That's the cancer. And you see say it don't breach the capsule and don't spread into the adjacent fat. Now, this is a more advanced stage disease than the previous one, even though it looks smaller compared to the previous slide that I show. And then, okay, this was supposed to be a movie. So this was basically just scroll through and, oh God, and you see, don't mess up. Hang on, let me see if I can rectify this. Okay. Anyway, the way I've been doing for show how when we scroll through the images, the different potentially highlight the different anatomy, because for this particular case, you see the cancer don't, in addition to the way it don't breach the prostate capsule, it don't spread to the seminal vesicles, the usai, the sperm cells they stored. And then they again other marker, because when you report the scan, you're not just the look, say the cancer, whether or not the patient get cancer. Yes, then at the first way you get for identify. And then you get for identify usai the cancer don't spread. So you look for lymph nodes around the area. You look if the cancer don't spread to the seminal vesicles, and whosoever else it might don't spread to. Now, generally, this one. Okay, so now with this, now when there's the stage the disease, okay, so you don't do the MRI scan, you've done the biopsy, and you correlate the PSA level with the biopsy, and then they give you a score of whether or not this patient potentially more likely for don't get prostate cancer spread to other organs. And one of the most common organ with prostate cancer they spread to now bones. And so usually in the workup, we do a bone scan, which is this bit. And if you look at bone scan, we inject the patient with the radioactive tracer, and it distributes to the body. It goes specifically to the bones, but when we do the scan, you can see impression of the soft tissue around. You can see the kidneys, you can see other things. But on this scan, now this area with my mouse, the circle, now the metastasis to the bone. So the cancer don't spread to that bone there. And I show the corresponding CT image where that's the iliac bone. And if you compare this left side to this right side, you see, say this one brighter, for want of a better word, is brighter than the normal side. So, and prostate cancer, they cause the bone for look more thick. And so on the CT scan, you did actually see, say, okay, this area of this hot spot on the bone scan correspond to this area of what we call sclerosis on the CT scan. So this patient already, the cancer don't spread to him bone. And the way we then go treat them go different from person where the disease just confined to the actual prostate gland. And then, okay, so this now 2 bone scan, same patient, 2 years apart. Initially, at diagnosis, there was no cancer, there was no spread. It was in the prostate. It was being treated with what you call watchful wait, so regular PSAs, etc. And then all of a sudden, in PSA jump. So PSA jump high, the need for okay, the cancer don't spread, so we did another bone scan. Now you see all the area now with black, now the ribs, the spine, the pelvis, all now the cancer don't spread. So in this case, this gentleman ended up with metastatic cancer. Now, this case was interesting because, as an innocent example, some of the things that people then go complain of pain, back pain, etc. This particular gentleman, na knee pain, he been they get. A knee pain, they get this knee pain, he need that, he need that, he need that. They go to a GP send out for X-ray. GP sent out for X-ray. Now, this part of the bone, so that's your tibia and your fibula, that's your femur. This part is what it should look as normally. Now you see how bright this area is. So that's what we call sclerosis on the X-ray. In a man, an adult male, if you see a sclerotic bone in a middle-aged to elderly man, the first thing we would think about now prostate cancer, and the first thing and the way you get for exclude. So the GP get this X-ray, send the patient to the hospital, follow the check in PSA. Checked his PSA, it was about 1,000, which is ridiculously high. And then this was his bone scan. Now, in the world of imaging, we call this a super scan. So any radiologist or nuclear medicine specialist where you not even need for describe the bone scan, you just they say, oh, this patient in a super scan they get. All man know what you mean. Because if I remember the previous slide with the bone scan, you could see the outline of the soft tissue. You see you see the kidneys. Where to make this super scan, all you see is the bones. You know, they see anything else. You not even see the kidneys, because the kidneys not the organ where they excrete the radioactive tracer. And on a normal bone scan, you're supposed to see the kidneys. Now, this is not super scan. So if you remember the knee joint, the very, very high activity, and then activity day, we delineate the bones so clearly. You know, so this man get extensive metastases, pretty much every single bone of his body, the cancer don't spread to. So this is not terminal case, palliative care, because there's no treatment, no curative intent. It's just palliative, you know, keep him comfortable for the remainder of his days. And then I think this is the last slide. Now, this again is a nuclear medicine. You know, do the bone scan. These are what you call your planar views. And then sometimes if we're not sure about a particular area, we do what we call SPECT CT. So we get the camera for rotate around the patient and you get a 3-dimensional image. And we fuse that with the X-ray or with the CT scan, and you see this area where you get this red crosshair is where the cancer was in the bone, and that's the corresponding fused image. Is that the last one? Oh, okay. And this again was another patient where initially he was been managing cancer with watchful wait. We no say they get cancer, then they check in PSA regularly, and then all of a sudden the PSA jump, and then do the bone scan, and as I've been seeing with the previous one, this one self now don't get super scan, so extensive metastases everywhere. So, but these are some of the things that we do from an imaging point of view. When we do the diagnosis and the treatment pathway for the patient. I think I'll hand over to Innocent.
Dr. Akpan, thank you. Dr. Innocent, they coming now?
Yeah, I think he's muted.
Oh, sorry. Okay. So, of course, as you see from Dr. Spencer's presentation, the staging, you know, can go along with the imaging and everything else. Although then get another thing where they can do, where they can grade as well, but that's for cancers, the oncologists for decide that grading in combination with other factors where they don't biopsy them, then they can determine, number one, the extent of how it's spread and the nature or the characteristic of the tissue itself. Then that, you know, Based on that, then we'll say this treatment, of course, then we collaborate with them and we follow the design of the treatment. I call on design because these days in most cancer treatments, you get for design a treatment around waiting available, you know, and also taking into consideration other factors. So they'll go to the next slide. Okay. So, like Dr. Spencer said, there's this watchful waiting. And there's also surveillance, active surveillance. Again, it's a fine line, really, to be honest with you. Certain guidelines, they talk, say, okay, if the patient in life expectancy, let's say 10 years from now, if the patient in life expectancy 10 years, then based on that, you can decide for design the treatment around the patient. If you know, say, other thing for kill that patient before 5 years, then probably, you know, cancer at the least, prostate cancer at the least of a worry at this time. We're not focus on the congestive heart failure stage 4, where you don't say for that, but make them comfortable. So the treatment really is based on then factors then they. Like I mean, they talk yesterday or which day we meet. One party day from all the residency then diagnosed him that with prostate cancer. It's many years ago, still they alive. But this was a man who not began any other thing with it going in. Even blood pressure was relatively in good shape. So, and the danger here is also when they do this watchful waiting or active surveillance, me prefer, again, look, you know, I can try for waiting guidelines or waiting a general practice, but I can try for waiting a me also personal preference. It doesn't mean it's correct based on national guidelines, but it just means in my own approach to things that way. Because unfortunately, sometimes some of you patients that you know that out of the hospital setting, so you know them cousin, that you know them picky, you know them family members. So if you do certain things and things go wrong, trust me, when I see them, will bring that up, you know. So I can rather focus on the types of treatment, beginning with the fact, say, active surveillance, I feel in every case, you can never go wrong with that. I'll go to the next slide. So beyond active surveillance, now the actual treatment itself now surgery, there was a time, I think I still remember, because a question I'll be don't ask, where I was just a new, I think a resident or an intern, we are finally see some people be done to move away from surgery. And the reason being the most common side effect would be the complaint about now urinary incontinence and then erectile dysfunction. You know, the almighty erectile dysfunction, man, and all that. So surgery was the common thing, but now I think they give other options. Radiation therapy, okay, based on the confinement of the cancer itself, because like it targeted therapy, and then hormonal therapy. Unfortunately, I shouldn't say unfortunately, because these are just natural things. When they give hormonal therapy, some side effects, and there were some patients and all that. So that also can be, because the waiting for ultimately a discussion between the physicians, the team, and the patient. Let the patient say what you comfortable. In some cases, they not get choice. You go just tell them, make it just tell somebody, say, now this I feel so good for you, but at the same time, the ultimate decision lies with you. If you're too worried about erectile dysfunction, then you can choose certain things. If you're not too worried, get Viagra, get so many things, it shouldn't be a concern. So hormonal therapy then can be, and then let's go to the next slide. Chemotherapy, usually if you don't spread all over the place, then you not get choice really. let them do chemotherapy. Now, some people can explain so many things why they don't want them, which is understandable because these are side effects. But we don't go to that stage where you need that, then likely because they deal with a 50-50% chance of it improving or not having any improvement regardless of treatment, then you begin to talk about other things now. Now, other modalities, they get the immunotherapy and then targeted therapy. So basically, the treatment is not like a one size fits all. You know, treatment depends on the characteristic and the limit to which it don't spread. Okay. Now, one thing where I want to add into this, we'll not discuss this, and it should have been like that screening part, but I'll be sure where it fits in. I think he's 70 something. There was a 70-something-year-old patient. I think 15 years ago, 20 years ago, and Dr. Spencer, you're probably aware of this, there was a research we didn't do. I say this because the person in family member approached me, why I not recommend later. They be give certain medicines. I think I've been tamsulosin, one of them benign prostate hyperplasia medicines. They be give for say they prevent prostate cancer. I say this now to every Sierra Leonean we'll see, or every African, everybody. Now, all study will be make that they do that. Waiting and find out about 3 years ago, the research says, when them people then take their medicine, where eventually then get prostate cancer, that they get the aggressive form of prostate cancer. So please, if you're not able, any friend, if anybody say this medicine will prevent prostate cancer, for let them not take it, most likely not their medicine. But research has proven 3 years ago, okay, we talk say their medicine and they. This is because there's a real person, 70, he will be 76 years old now. Maybe they take him. We ask me for there again. Well, I say no. I say research don't prove. This was 3 years ago. And luckily for me, I had just read that research maybe a month before, where the patient asked me. True, real person living here in where we are. So I tell the person, say, no, research don't prove, say, you're not there. They say, oh, well, I get one party now they take, you know, if I don't go back home to Africa. I say, no. Research don't prove, say, not good. Right now, as we talk, that person will go through treatment for prostate cancer. So please, if you know anybody with them, say, this medicine here, there was another patient, but not a prostate cancer killer, or something else killer. We meet, you know, a black path. Me and get this conversation till to the point where they say, oh, me no nothing. I say, you may assume that you're correct for think so because you meet minimum. If they take a group, I would say like a concoction of medicine, and we say they don't do research, they prevent prostate cancer. He ended up having prostate, not to the prostate cancer killer or something else. But their advice they are what they give, go take this, they prevent this. I really don't know who side and they put the information here. If then tell somebody that maybe in research would then do 15 years ago, but any other thing, it does not prevent it. I don't want to take my time, but please, if you not see anybody where they say this medicine are good, this herb are good, when I tell them, say no, discuss with your physician first or pharmacist, because whether they take them thing and they the side effect later, nobody knows. And since we don't really know what is the triggering point besides the genetic linkages we'll get, it be better for stay away from all the hafting where people go and sell, say this will prevent prostate cancer, because you might end up forgetting aggressive form. Yeah, I think that's the last line.
Thank you so much for that.
Whoa.
Welcome.
This prostate cancer sounds so aggressive, so intense. Whew. Bumike.
Dr. Tambi.
Yep.
And Dr. Spencer, thank you very much for unpacking a lot of the mystique surrounding prostate cancer. In as much as we simplify the information we want to give you vital to just we all around decision making process and just in the way we can do. of course, some of the thing and they will know but it needs to be said. And I think that role they make him play at this show as the layman, the man who not go medical school, but are surrounded with friends and family where get the experience we wanna get. So I can help relay them to me and party them where, you know, see me as, you know, not the doctor, not the nurse, but as a guy who just interested for like all man, you know, get Wellbody. So on behalf of we the audience, basically, I just say thank you. Today I noticed say there was so much going on. I don't know if you get any questions on your end, Rachel, but me not get no questions on the end, and I not see nobody put any questions in the chat.
I've been seeing a question from one of the twins. I think he did talk something about red meat. I not see the question again. But I know say there was a question about the I know say it's still the live. So
Yes, Rachel, the question was whether red meat increases the risk. I wasn't sure if it was rhetorical, but yeah, that's the question.
Oh, okay, thank you, Tanya. Yeah, because I know I just see them briefly. So yeah, over to the doctors, and we just want to acknowledge Dr. Mafudi as well. Say it just joined we, and so obviously now one of we doctors they're working it regularly. So I don't know if you said there's something for say at some point, but just while we acknowledge Dr. Swari in presence as well, I just see online. So Dr. Spencer, Dr. Tambi, the question is about red meat. If red meat, they increase the chances.
Yes, I think when we talk now, I mentioned that, yeah. And I don't do a lot of reading, and waiting me discover, and I can just say red meat, because almost always, they associate consumption of processed meat, basically red meat, usually from all which they read, that it's associated with a higher risk of possible higher risk of prostate cancer. Now, again, some of these things, somebody will do research, will say, this is not the case, that is not the case. But because I don't read on so much, I can just make an a duty for explain to people. Just the same, similar to colorectal cancer, wouldn't they associate with, you know, yeah.
And me, the question maybe want to ask Dr. Tambi, I noticed that you be talk about this digital rectal exam a lot, and yeah. I don't know if you, because I don't know if you go able to explain to the gentleman there within the audience what it entail, waiting them for expect, you know, okay. When then go do this test. I know. So, you know, between also, if we're not going for touch on that, please, waiting them for expect.
Well, yes, we not go
Dr.
through
Spencer,
something.
I don't know it's to make you laugh, but it's a very serious question.
Here's the thing: we not go through something, they assume say it's very uncomfortable or bad. However, maybe because we don't in the medical field and we don't do some things that don't seem like common to, right? And from what people they tell me that you're uncomfortable, but I want to let people then look beyond the discomfort and look at the outcome, what's in the possible outcome will be. Like the possible, I tell you, real people that they talk about. So actually, now one of the people that I want to let it come with like a link for talk, but I'm willing. Where I say there was that big difference between 1 year and the other in PSA count. Because to him, you know, it was uncomfortable. So all you get for them, I don't know if I describe it in the most respectful way, okay? Okay, you get for put your palms down. The doctor, they take a glove, put some gel, then you lay on your side. Then you put a finger at the rectum, you try to feel the prostate, the gland, like this. Okay, and you feel, not to just, you know, you go past your hand, no. You feel for see if any abnormality, the one side bump past this side, if the nodules, then the way they notice, or anything. it increase heightened awareness to the doctor himself, even if you be in doubt. And you feel, oh, firmness as well, because someday it can really hard, and that can raise suspicion. Yes, you're uncomfortable, but if you're able to drink before you go there, man, anything we can do for make it easy for you do. I don't really know other way for describe. Maybe a man go get way for describe. We're not go so bad. What do you say?
Well, you know, it's well, yeah, it's no we're not there for sugarcoat up. That's basically what happens. You get the aim as the healthcare professional, I would try to get the patient for be as comfortable as possible. So, you know, yeah, strip, put you trusses or whatever to knee level, lay down at the bed, lay down on your side. When the 10 away me being they see patients, because now my patient interaction very, very limited. I can tell them, lay down on your side, try and bring your knees as close to your chest as possible, because then they supposedly shorten the shorten the passage. And then you tell them for relax, because if you're tensed, it's going to make it more difficult. So try and relax. And the finger's supposed to be in a glove with some lube, and it's supposed to be easy. Now, I remember though, Nakomas, what would they call us? We had this famous book of surgery, which was, you know, famous in pretty much the whole of West Africa. I've forgotten the title, but it was written, one of the authors was Professor Achempong, and he was also one of our lecturers. When I began Comas, he been the lecture anatomy, and then obviously in the clinical years, he been the lecture surgery. He was one of the gurus of surgery in West Africa. Now, in that book, this is not a joke. Anybody read that book, they will tell you. In the first few chapters of that book, when they talk about where you assess patient, this wasn't even now for suspicion for prostate cancer. When there was the belief then that any patient with abdominal pain should have a digital rectal examination, because potentially the abdominal pain could be obstruction, etc. And so then forget digital rectal examination. And I remember vividly the line at the book where say, the absence of gloves is not a reason not for do the rectal examination. So that's it. If gloves not there, take your finger, you fan soap. So you put your finger inside the soap so that under your fingernail, you get half soap under your fingernail. And then you do the rectal examination with your empty finger. I remember the first day where I read that, I was like, hell no. That's not gonna happen. But yeah, so for we, not to anything special. Plenty time that we know if you really want to do it, but it has to be done. And so we all role now for try for make the patient comfortable and do what you need for do. Because at the end of the day, if you think about the discomfort for you get one finger for examining your prostate compared to potentially down the line when they need for do biopsy, then they put a whole ultrasound probe. Then they're a lot more bigger and a lot more uncomfortable. Or potentially you end up with prostatectomy where they get for pull the whole prostate. So you rather suffer the small discomfort at the start for let them tell you say you're clear, or potentially you might have cancer which is detected early and you get treated and you survive, as opposed to you the shame, how for go through that discomfort today and you end up with terminal disease.
Yeah. Thank
I
you.
think say, I think everybody they read the messages. I see one nice one. For those men who are cringing, not to me right now, I'm innocent of that. For those men who are cringing, when my name come in handy now. wait, try being a woman and having pap smears or going through
Exactly. If we
when
dey
you
get
are
upstairs,
look the last part now I love cervical exams when you're in labor.
exactly.
Boy.
So
Me-
in Canada, don't give us the answer.
You know, and I don't know, and I don't mean this to be funny. Some, you know, another stereotype. I know, say like African man, then sometimes then get a lot of issue with maybe another man touching them back passage, especially if they, you know. So that's a fact.
That's a good point.
Even you know,
That's
like I
excellent
see,
point, Rachel.
and I'm gonna call him out. I see me man very active na the chat they talk say not to buy force. Yes, not by force. So
How you can't disgrace the man?
now
So
get
it's
for
it-
call
so-
him out because you
this-
get for understand say Bumike,
this
you
is
know,
the-
young like you anymore. Now
Yeah.
man
So,
of
wait,
a
so,
certain
so Rachel, are
age.
you saying they should find a female medic for your
No, well,
man
you
for
know
who
what
get
thing?
erect?
I kid you not. I try for sure. I'm waiting for expect, but even with that, he was not having it. But you know, I think same man then sometimes go prefer it go make them because to me, una young sound easy, sound like fun. Compared to we, wait till we they go through as women. So, but I think so maybe if not a woman, they do want to una go feel more relaxed than when una company man.
I don't think. I mean, personally, I don't think that should make. I don't think say for make any difference. At the end of
It
the day,
shouldn't.
I don't think it should, because at the end of the day, me own mindset is the end justifies the means. I don't mind the rectal examination if they're gonna tell me, oh, we've just detected early stage prostate cancer, come sort you out. And you know, 10, 20 years later, you're still here with your family, as opposed to you left there, oh no, oh, that's a bit, and then you end up with advanced stage disease where nobody can do anything for you. And
unfortunately, Dr. Spencer, we know that the reality in our community is a lot of the times we man then they die because then go, you know, they're not. I see Tanya put, will they rather get sick and die? And unfortunately, the reality is a lot of men then not they approach medical, then they go for sick medical help. You know, like. The thing is, especially in London, Bumike, I don't know, you know, say in the past year or two, we don't lost a lot of people away. Me and you know, like the names, them prominent names there. And really, now because of lack of medical intervention, early medical or timely medical intervention, by the time some of them people and most of them then this salon feel pain some size say, okay, Lord, return back na England. By the time they reach na England, it was too late. And because the story behind it is, you know, before they even travel, then we don't encourage them, say, una go to doctor, then kind of symptoms there where they talk about. So you know, it's unfortunate, but the reality is, especially with brothers, them, we really, they really need forget everything where them believe in. You like what you say, Dr. Spencer, you said something. It shouldn't. You didn't look at from a doctor point of view or everything, but really, now look at from usai we come on. An African man go rather a man not touch him than you know it go stop them.
No, but
times, you know,
if I can come in, me na African man.
Okay? I know, but you're not Dr. Spencer.
No. Me, I did give myself as example, as in me personally. Me no go think twice if I have to, all right? Because me survival a lot more important than the 30 seconds of discomfort. Okay. And like also in my own case, personally, I don't lost family members, right, to prostate cancer. So for me, I dare a higher risk than other people. And again, you know, black man and all that stuff there. So I'm in my I am still young, okay? Last month, I go to my GP, and you know, obviously, my GP no say me na doctor. So generally, we conversation who they get now. I think say I dey feel this, I want this and this and this test. Then she don't the right time. They send me go, I go do it. So I go to my GP, I was like, look, you know, here's my background. I want to do PSA. Yeah, send me PSA. PSA results normal. And at my age, nobody, very few people go even think about that. But the whole purpose again of this show now for encourage, for start the discussion. And obviously people then at the background see we all, you know, we all young, we all age group, some people, you know, slightly more advanced than others, you know, with very extensively white beer. You know, but still, at the end of the day, we start the conversation and we break the whole taboo, and potentially that might encourage more people to go seek help, which was the whole idea behind this show anyway. So, you know.
Akpan, like you always say, if just one person decide to seek help, the show is a success.
Yeah.
Yes.
Yeah. Just
I
one
guess
person.
somebody asked a very important question. It say, can the test be done while on anesthetic?
Yeah.
Now, I don't know, because the person will explain further whether they require for get anesthetic for doing or not. I don't know if that I mean, or if it's so painful, but it's not painful. If it's so uncomfortable, if you ask for them to do anesthetic. Now, Migo say you don't need general anesthetic for this.
No.
It's still when at less than 1-2 minutes maximum. Worst case scenario, if a patient tell me that, because now the first time they see this kind of question, but now they think to myself, if any patient I want to ask for this, you know, we get for still make people that comfortable, let us get the job done. I don't know if you go ever walk on, I never try. I go put general anesthetic and around the anus, local anesthetic, around topical anesthetic. Maybe you go walk, you know, because one time I be the walkout patient, I be the pull something around the boy in somewhere in here follicles. So your body panic, you know, one needle. So I've been needed, injected anesthetic. I say no, topical. I say, well, I'm not sure if topical will help. So this person a genuine question. So me go say to this person, if he actually very uncomfortable or afraid, let telling doctor for apply local, where after that it will be known for a while, but I'm not sure, you know. So,
Dr. Tambi, I actually know of doctors who use topical anesthetic because
do the rectal exam. Okay.
Yes, for do the rectal exam. Yes.
But this is an important question. So if anybody there with the fear, let take this man in question important, let ask him doctor.
Exactly.
Yeah.
And then another question that came up that I thought was interesting. Somebody they asked if, let we say the man gets prostate cancer and he's having intercourse with a woman. Is there any way it's transferable in terms of trigger other types of cancers in the woman?
Cervical cancer.
Like cervical
Exactly,
cancer.
vis-a-vis cervical cancer, yes.
Well, the thing is, prostate cancer not to STI.
No.
So it's not an organism that transfers. And in terms of, so for example, with cervical cancer, there are several links as to potential, again, what causes cervical cancer, but just having sex doesn't cause cervical cancer. So I know I just struggle for see how
Okay.
if someone has prostate cancer, whether it could be transferred. I don't think that's possible.
No.
Okay.
I've
So
never heard of
that
that.
answers that question then.
No,
But-
well, let me educate the person. Let me educate the person that for cervical cancer, there is a clearly defined, clearly understandable process by which it can. And the fact that prostate cancer gets a different, completely different mechanism. So it's number one, it's not possible that even if those tissues then found in that sperm cells, then they go there and harbor somewhere in the cervical area and cause cervical cancer. Cervical cancer completely, clearly defined organ, nothing, no commonality in terms of origin with prostate cancer. So let that person not get that fear. You see, let me try for really make people to understand, say, we can talk about these things expecting older people, but because I don't see younger people that get prostate, when I say young, I mean in their 40s. Let's really encourage people to seek early, somebody write in the comment section, early, was it detection, early something, or go early to a doctor, feel comfortable for discuss these things. Like when Bhumika say, if now one person, then they should, because that's the most important thing. We can talk for 10 hours, we can talk for 50 hours. But if people do not feel comfortable, absorb and understand and utilize the knowledge for go do something, then nothing is achieved, you know? So yes, no relationship not between the pathophysiology, the way with cervical cancer they take place and the way prostate cancer they take place.
Somebody asked just now, Bumike, somebody asked, say, if your testicles then shrink, I suppose they try for ask if then they get anything for do with prostate cancer. If they get experience that your testicles that they shrink. I don't know it's in the limit.
Well, various things that they cause so-called shrinking of the testicles, but not to prostate cancer necessarily. With age, they likely get smaller because they produce a larger volume of sperm. As compared, we expect a 70-year-old man forget like the testicle the same size we can get when at 40 years old because the production don't drop. Now, that's also controversial to some extent, but let's get a general understanding that shrinking of the testicle does not correlate or is not related to prostate cancer.
Okay.
There are so many debates around that topic, but let that person just get the understanding, say, no, nothing to fear. Just do your regular exam, encourage your doctor. Hopefully the doctor not go ever talk, when I turned 40, one of my professors actually, Nana with me doctor. So a surprise, I tell her the day I turned 40, now I tell her, say, I want digital rectal exam. First year come on, I met. They say, I thought African men don't like, would not like digital rectal. I educate, I said, no, I'm not going to accumulate all this knowledge there, sit down and back. So the same thing for the people who they ask these questions. They're not forever hesitate for ask as many questions as they can. Being African doesn't define who you are in terms of your health, because where disease comes, it comes.
Yeah.
And if we go back to the whole shrunken testicle and what's in a sense say about as you get older they shrink. Maybe now that we know we should be aiming for 21 a month, maybe that might change.
Boy. Oh boy. Well,
you can forget in trouble for that 21 way you talk. So
this is a very nice way to actually segue probably to the end of our program, because but before we do that, I want to acknowledge one part we doctor then himself religiously, if whether I present or whether I not present, she tunes in and she supports. And then Dr. Desta Ali. And she's online, and she even tuned in before me today, and it only support this program from day one. As a group, we just want to say thank you and thank you for supporting the program. So with that being said,
hang on, sorry, Bhumika. I've just seen a contribution by Dr. Ba, who's in the urology department in Sierra Leone.
okay.
I don't know if we can ask him if he wants to just say a few words about potentially what happens over there.
Absolutely. Dr. Ba, are you there? Hello, Dr. Ba, are you there?
I see still there.
Yes.
Nabi. Yes, it is.
Okay.
Good.
Dr. Ba,
Good
welcome to the
evening.
program, sir.
Yes, good evening.
Good
Hello,
evening.
Dr. Ba.
How are you?
Fine, thank you.
So, me, I see the registrar in the Department of Urology in Sierra Leone.
Okay.
I'm working with Professor TB Kamara, and also I'm part of the urology team in Connaught. So we have so many constraints, as Dr. Akpan Spencer mentioned. Number one, most of the patients they present very late, as I put them on the text. Most of them they present with locally advanced disease, meaning that the cancer don't spread from the prostate to the neighboring tissues there. So that's now one challenge you get with the patients there. And most of the patients them they come to hospital with symptoms. Then we know they get patients that really come, for example, at 50, doctor come for screening. So most patients in the car with either urinary symptoms, or they carry with lower back pain, or symptoms of metastasis, breathlessness, cough, or some can carry with jaundice as a result of with metastasis to the liver. And most of them are end stage. And in terms of investigation, also we start with clinical investigation, the digital rectal examination, and also we do with PSA, and we can also do with imaging, where we start with transrectal ultrasound scan, because it's more available, and you get to consider also the cost. We only get one MRI machine, we available in the whole country from EcoMed. So, and it's very expensive for patients. Most of our patients, them are retired people, very old and retired. But they make use of the ultrasound, the transrectal ultrasound, for making a diagnosis. And from there, we can make histological diagnosis, because we say they do 2-cut biopsy. And we can, most of the cases, them in advanced cases, so we can manage them palliatively. We can either do surgical castration or medical castration with hormone therapy. But the hormone therapy is very expensive. As we can see, for example, like the 1 month injection goserelin, they go for about 1,500,000. And the 3 months, most times think they go for 4 million. Considering most of the patients, they're very difficult for continuing treatment also, and for the check them PSA, which is about 300,000 every 3 months. It's also a challenge. So most of we get challenge to patient them on financial grounds, but there are other patients that can afford, as we all know. So, but majority of the patients them, they get problem for continuing treatment. Some the starts, then can just disappear in the clinic, but we can understand saying because of the cost of the treatment. And I don't know how we're able for, even for the sensitization of these patients, for the population as a whole, because as from the presentation, one of the risk factors are age. If we can get men them at the age of 40 to 45, we voluntarily they go to hospital for screening, we're able to get a better figure of the cases they will get. We get a lot of cases for prostate cancer. We get over 300 cases they will manage presently. So the incidence is high. And this is not just the one they will capture with they come with signs of local invasion. Not so from basic screening. So thank you very much.
Oh, Dr. Ba, thank you so much. That was quite emotional for me.
Yeah, Dr. Ba, you give me a whole new perspective on the conversation, you know, and that was invaluable. And I hope say, you know, since you be part of this program, I formally extend another invitation to you. We're gonna need you in the not too distant future. You go hear it from we, and I should say you got other colleagues and stuff we go contribute to the conversation. And the whole point now for just help we as Salon there for make better informed decision them and for make better choices about we health. So you know, and you really don't contribute to this. So thank you again on behalf of the
Sam have been saying a question for Dr. Ba. Sam?
Okay, Dr. Ba. So you mentioned desensitization lead to prevention. Actually, do we help? Waiting at the plans for that.
You're not clear. You
Yes,
sound...
you know, yes. I know they get you clear.
Samakaya, so you use this one.
You can hear me clearly now, right?
No.
Yes.
Because not the same line will to deny me.
Okay, Dr. Ba, sorry, you mentioned desensitization and you know, prevention and all the other things, and is there something they look for put in place? You get something you look for put in place, you get grassroots, you get things where, because a while back, it's something it's something we considered working first with churches, you know, like maybe after a Sunday, now a church, some pre-screening go there, you know what I mean, eh? On a smaller level, maybe it's maybe not your old school doctor, on maybe once a month, people go there and, you know.
What's my question about pre-screening?
Yeah, about pre-screening and setting sensitization programs for people, raise awareness on the issue for people. And not say people in a salon then get other issues their way generally can they bother them. So sometimes somebody who they think say, oh, me not getting for it, wait till they go to map worry about, going up in a program for. So if you get something we want put together, can you let us know? Let us know how we can.
Or waiting already dinner.
Waiting already there in place.
Sensitization.
Yeah, in terms of this sensitization, if there's nothing in place and you're thinking of doing something, please, you can let us know what you try for do. So as a team, we will see if that's we're able to help with.
Yes, because I start the urology unit a few months ago. I'm a member of the West African College of Surgeons. So I've been trying for put in place, if I were able to start with radio discussions. And from there, we'll take them to another level, but involving the chiefs, them, and the other people, them, the stakeholders, and the communities, them, for see how we're able for help and try for sensitize people. But you know, it involves a lot. And when you come to screening, prostate cancer screening involves a lot. And as I say, the cost for PSA is about 400,000, 3 to 400,000 leons. Imagine you get 3 to 400 people. That's a huge cost. And as I say, that's a huge cost. It go very difficult for graduates. But we try for see wetin we able to do, and if we able to get support from organizations or from governments, and see how we go able for carry on the exercise.
So right now, basically nothing are in place from the government for help for screen people them. Is that, am I correct in saying that?
No, for now, except
For
again
now.
for rights. Yes.
Okay. Well, you talk about sensitization and starting your own program and stuff. I mean, obviously you're here on this platform, and as Africans, I think it's important we all work together as Sierra Leoneans. So this could be a start. I mean, you could be a part of something like this as well. We get people in from America, we get people in from here, we get people in from Salon. We could all work together collaboratively, and you go get the way where yourself go share this platform where it go reach a lot of people them back home. And so then go hear from your own side, and we go hear from your own side as well, so we can start the sensitization program now, because it's all about information sharing and collaboration. But we really appreciate your contribution. It's been very valuable, because most of the talk in the talk or the discussions that we can take place on this platform, we not can get really, we get somebody from tongue, but the more the merrier. So it helps that we get somebody we're able to tell, we give away a realistic picture of waiting at the situation of this very important topic they discuss. So thank you very much, Dr. Ba. Bumike, I'm gonna go over to you now.
Sorry,
Thank you very much.
Talk. This is not Dr. Julius Spencer.
Well, Dr. Spencer, I'm not going to talk before you, sir.
Hello, Dr. Spencer.
Welcome, Dr. Julius Spencer to the program. Of course, you always add your own Lily Pepe to the program for make it more special. So thank you very much for joining, sir.
Thank you. I mean, they do a text message, but I get problem with me. Yeah, so I know the C for text. I want to make a few comments. First of all, the whole question of sensitization, waiting Dr. Bassi. I think you get two categories of Sierra Leoneans. The one that we can afford, the way they just not know, waiting for you. I'm surprised when I talk to party them around the same age as me, when I know nothing but prostate cancer. They don't know about PSA, they don't know, and when I talk about digital rectal examination, I've been a bit confused. I mean, I wonder if some equipment they wait and this for do the examination. I don't know if na finger, now they call digital, then I doctor them. Because from waiting and see, now finger to the end. We don't do that examination twice. I they check me PSA between 3 to 6 months each time. But a lot of people don't know nothing. I think perhaps Dr. Ba, I go reach out to him. Let we come up with some sensitization, many medical issues, kidney problem, hypertension, but people then they die in a salon because they don't know. Then they get symptoms, they know they take it seriously, they know they go to hospital. And as far as prostate concerned, there's the whole issue of man them where they shame for talk when they get some of them symptoms there. So then they carry on with them and they waiting and they get or urinate and get so many symptoms. They know they talk before I say go hospital self. So then web self know they know. So I think a lot of sensitization need to take place. I think the Medical and Dental Council or Medical and Dental Association need for come together for educate the public but on the so. And me willing for help. So I'm going to communication. And I can help if the doctor them prepared for do that. This program educating for we were able for link up, we get access to technology. But not all man, beaucoup people do not get the access. And again, secondly, the time when I did my wife don't sleep safe before the program. Governor can remind me about the program and connect for me, but I don't sleep. So I think so I probably need to consider the time when I did one. Secondly, for winners alone, the doctor they need for do a bit more in the area of sensitization for let people then know what then disease they are so and waiting them for look for as far as symptoms for let them go hospital. Sorry for butting.
No, Dr. Spencer, the real Dr. Spencer. Thank you very much.
You just went flower.
Thank you so much, ever so much for your contribution, and we appreciate like always you do and how which you can always bring to the table and your perspective. So thank you very much. Rachel, me no get nothing more for say.
You see? You see?
Oh, now, hey, Dr. Tambi, you know, say if Dr. Jarrett can this program, we'll get for extended for another 2 hours. You know that. Hi, Deji. Welcome to the program.
You know what? Speaking of which, Deji, we need to have a dental one because dental health is also very important.
Yes, it is. It is. That brings to mind. So Deji, we will be reaching out to you because we're gonna have a dental program, and we're gonna look for the you spearhead them. So, Salon just get too much local talent and too much local knowledge, and all things for let just go down to waste. We'll get for big up with moving forward, and the easiest way to do it is to share information and let we enlighten ourselves, encourage ourselves, because these programs are very encouraging, seeing the way we can laugh about. Where we discuss and we can realize the severity of it. Like this prostate cancer conversation, it's serious, and we play, we laugh, but at the end of the day, not life and death we talk about, or just quality of life. So these things do matter, and we cannot say thank you enough to the doctor them for Leona emphasize until we say let we take them thing there seriously. It's not a shame business again. I mean, we're adults here. We all get relationship them. I mean, one way or the other, we interact with our significant others. So let's just kick the shame out of the door and let's take we life seriously.
And Dr. Soye said two things then. One, he say if the doctor they're not ashamed, why make you the patient ashamed? If the doctor then comfortable, why make you the patient of? And then he say another thing where he say African man then they let them pride themselves in their skills in the bedroom. So if they go rather, because then they all go down the drain if they not go check themselves properly. So it better let them go check themselves so then go carry on for enjoy.
A lot of times, I go right. A lot of times, there are a lot of people who are underperforming, and simply because they know they go check, and only they can go check, and these, the sky is the limit. So let we take them in there serious, and hopefully, on the next topic, we can piggyback off of this, and we will just strive and continue to get better.
Okay.
Okay, you go get for tell me say you go learn that you medicine there.
Listen, Akpan, most of the thing the way you say don't make it upset, but it don't seem for calm down. Please not start other one.
Of course, you had to have the last word, but I trust you this one. Ladies and gentlemen, thank you so much for tuning in. It's always, busy on a Friday night, but when I can find time out of on a busy schedule for the new one, when I welcome to the program. For the one day we don't support you from day one, we love you guys, and we'll continue for strive for be the best and do the best. And we'll catch you on the next program. Again, my name is Bumike Smythe, and I'm one of you when I moderator them for this program. Over to you, Rachel.
And Mina Rachel Bania, Mina one of the moderators of them for this program. I know say we put this notice in the beginning of the program, but just want to reiterate, everything here with the doctor, then they say now this program not to then they make diagnosis, then they tell una still need for go seek una medical health. Una help from una medical, una GPs there, una general practitioners there. The doctors then go guide una down the right path, then go give us then suggestions, then share the experience them, but they're not the diagnose una with anything. Then it's una say what whatever so una still go seek medical help. Okay, and then so just before I go, I just want to say thank you to everyone from behind the scenes, Tanya Coca Ferguson, Sama, and DJ Weaver, he's back. Good to have you back. So many like Seok, Ayo, doing all this hard work behind the scenes. Tanya, for whipping us into shape. We cannot stop. I mean, it hurts, but we still thank you. And without you, this ship definitely go in our shore by now. But we thank you for the doctors. They even, like Bumika said earlier, the one they were not even there on the show, Dr. Ali. I'm sorry, I didn't mean to miss you. Dr. Soiree was there with her little Baba, and I just saw that and I was so excited. So Dr. Ali, I didn't forget about you, but yeah, thank you guys, Dr. Ali, Dr. Soiree, even when we're not a part of the panel, we're still there for support. You've been here since like 7 o'clock behind the scenes in the meetings and stuff, making sure this, and we thank all, we see some of the same names then back, they come. We thank Kuna. I want to give a special shout out to Mrs. Weaver. We saw your comments, but we're not going to provoke you, man, this next. So. Una, thank you. Una already take una time out. The one that we're not today, then first join we hope so una go come back next. And this now a program where we do once a month because we're not for overwhelm una with information. So once a month, we they meet up for can talk about health problems them where they affect people them of a certain age. Well, actually everyone really. We resident doctors them, but we also get guest doctors that we can come for can share good information with una. And obviously, Bumike earlier they tell una that it be Miss Efna Bella. Well, Bella Donna on Facebook, but Rachel Bania. So una, thank you very much for tuning in. And guys, please check.
Dr. Tambi and Dr. Spencer, thank you so much again. And I know we'll catch up soon and we'll see soon. Thank you, and everybody have a wonderful weekend. Una can hang around. There's going to be music afterwards, so we can hang around. And whenever you want to drop off, feel free. But thank you again, and see you on the next show. Thank you.
Dr. Spencer Senior, if you're still here, extend regards to the mommy. Thank you for joining us.
But you must hustle if you want job. If no finish, they won't fight us. If them they run, them no fit catch up. I know they form say I too righteous. No con they form say you too like us. You no get the time for the hate and the bad energy. Got my mind on my money. Make you dance like broccoli. Steady green like broccoli. Steady on my grind, oh yeah, what they want telling me. Could deny my fantasy. They want to check if my tapping. No. Bad man looking good in the bad man drip to the car. Sports cars parked on the right spot. Bad man slick and you know. Bad man looking good in the bad man drip to the car. Sports cars parked on the right spot. Bad man slick and you. Me got a girl on me bed right now. She says she no one leave. She tell me, Ruga, me I want to spend the rest of me life with you. Me say no shit. Oh Lord, fly you to Maldives for a day, then we fly back quick.
DJ Weaver, one dance.
Who's casting at DJ this Babella?
Yeah, log off one thing. If not, then they carry it. The program done.
Somebody
because
say
another
Arsenal,
Man
and
United
we're
man
top of
there,
the
we
league.
not get one shame.
You can take shots at Arsenal, man.
No,
We live in
man.
the league, so we run the world. All right, so
Arsenal,
bring
we
it
there
to
on
Qatar.
top. We there on top.
Anyway, the girl doctor.
Last year, what we know,
young doctor.
Bella, you don't tell me say don't move go to United. How you reverse cannot know.
Look why the life is there. Who's the me? I can't left me so bad team for that one. I left when I give Ronaldo.
I think Asama for come over to Arsenal. Ronaldo don't show with you.
Marge, try come over.
Marge in the building.
Hey, Marge.
What me go do Arsenal?
Marge said DJ Weaver they play like Arsenal supporter.
DJ Weaver an Arsenal supporter. We know them.
DJ Weaver, you right. You they play like Arsenal supporter. You they on top. We they on top.
Thank you.
Bad man looking good in the bad man drip to the car. Spot car, parked on the right spot. Bad man slick and you know. Bad man looking good in the bad man drip to the car. Spot car, parked on the right spot. Bad man slick and you. Me got a girl on me bed right now. She says she no one leave. She tell me, Ruga, me I want to spend the rest of my life with you. Me say no shit. Oh Lord, fly you to Maldives for a day, then we fly back quick. Then we take a quick jet, fly straight to Paris. You fucking with the creme de la creme. Say she never seen a guy like me. Yeah, she confess. Say nobody hit it right like me. She confess. Men don't get on your knees, girl, never digress. Ooh, she really wanna flex with me. She wanna break bread with me. Bad man looking good in the bad man drip to the car. Sports car, parked on the right spot. Bad man sick and you know. Bad man looking good in the Choro, 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 da, choro, 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 da, choro, 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 I'm a choro, da, choro. Oh, yeah. I don't wanna lose you this time, I win it. No time, I'm gonna winnie, wanna your love, they do me one time. Oh my, I'm gonna move me. Show me how you feeling this night. I'ma say your love, say now winnie, wanna your love, they do me this night, yeah. I need your grace, me never relent, my love no get shame, no matter the case, my music give me bass, my sweet, sweet bass, so my love no get shame, for you all day, every night, every day, me go need my baby to call on me, close to me, yeah. By the time when you dey wake up in the morning, man, I dey buy you side for me, make you fall for me. Oh yeah, choro, 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 yeah, choro.
I need you in the morning, but I need you now. Yeah. I find you, I give you all you need. I know what you like. You don't need no other body. You don't need no other body. Only you feel on my body. Only you feel on my body.
Baby, trabalhei, make you know they shall like it. I don't want nobody to keep my matter killing. For this life I day, I want to be celebrated. Don't wanna waste my days, I want to spend them on enjoyment. It's been too long, not turning this you every day party.
If I follow politician, you go hear am for paper. They go call am prostitution. Who no like enjoyment? If money dey for pocket, shebi na national budget. You, we go blow like trumpet. Koroba, 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 koro. We are carry ya. Koroba, koro, koro, koroba, koroba, koro. We are carry ya. Koroba, 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 koro. We are carry ya. Koro, koro, koroba, koroba, koroba. Oh yeah, everybody carry ya something. He say, darling, I'm watching you. Something you don't know. You come, they shout. Money, you know what I say.
I don't change my energy. I no get time for no enemy. To repay to me. Nothing with person never see. I'm on nothing with person never see. Forget it, I say bashi. Money soon expected. Take our body agent. I take her to the person. Jelly. I'm in the answer, yes sir. Then I'm in the answer, yes sir. Respect is reciprocal, even though I know say special. Anybody, we no want to surgery. Anybody, we no the carry body. I can't something, I can't something. To bata fele, I can't something.
My girl say she wanna fix and chill, so I chatty get you and one. If you fall in love, Kelly satin. You go to breakfast, I'm not catching. Can you see the pool, I'm not catching. I'm not faking this, no fugas. You see these feelings, I'm not catching. I'm on quest and feet, I just want it. If I broke, I'm a business. I'm a child, you go like. All I get for the night. If I broke, I'm a business. I'm a child, you go like. All I get for the night. You get your love. Girl, I don't give you all I got, but it's not enough for you. Say you fire me, catapult of you. Now I be say I don't be getting enough of you. Yeah, waiting me down, nothing I can't do for my baby, my baby. Anytime when you need me, come to me, my shawty, wallet. Waiting me down, nothing I can't do for my baby, my baby. My shawty, oh, they my baby, say you there for me. As I there for you. Big baby, say you there for me. Low key, all of them done they notice. I'm not joking, all my guys, them know me. Since 06, I've been writing this story. I know be OG, but if you ask them know me. I know they blow trees, only lonely me lonely. Music chose me, just know this and know peace. I dey low key, but I'm never lonely. Sexy ladies, come wine for me slowly. I love you, I see, I make me believer. I became a boy, I'm a sinner. Yeah, nobody will give over. I thank the Lord, I go far. Who's the gold that I get back? Just on the window, she died. And then I do it too bad. Midnight, I got she died. They never see me coming. See me coming. Go. The one is coming. Yo, oh, yo. I can't buy it for you. Go for you. Problem, you know the finish. We can try to enjoy. While I know the finish. We can try to enjoy. Sekata uru no the finish. We can try to enjoy. Problem, you know the finish. So we can try to enjoy. We could dance like Luala. Yeah, Luala. We could dance like Luala. Yeah, Luala. We could dance like Luala. Yeah, Luala. We dance like Luala. Yeah, Luala. Why you problem, you know they keep person. I a person keep person. My online is still finish. I question that person. Problem, you know they last forever. Take you try to enjoy. I walk up from Pelemuja to Apollo Meta just to find a mentor. Now who talk they hear what? Now who watch they fear God?
You got $100 bill, get your hands up. You got a $50 bill, get your hands up. You got a $20 bill, get your hands up. You got a $10 bill, get your hands up. Single ladies, I can't hear y'all. Single ladies, make noise. Single ladies, I can't hear y'all. Single ladies, make noise. All the chicken heads, be quiet. All the chicken heads, be quiet. All the chicken heads, be quiet.
TJ Weaver. Now you last go die, brah. Give yourself go belly.
I know, say Bella, I get for do your exam soon.
Dr. Spencer don't care. I mean, don't care.
Almost everywhere. Think of all the things that.
Anyway, guys, me they go sleep there. I don't wait for my first one this morning.
Dr. Spencer, you do well or you hang? You hang.
I'll do all I can to keep you satisfied. So just in case I don't make you home tonight, baby. I don't make you home tonight.
Everybody move your body. Now do it. Here is something that's gonna make you move and groove. Hey DJ, keep playing that song all night, on and on and on and on.
I gotta get the best of you. I gotta get the best of you now, baby. I gotta get the best of you. I got to get the best of you, my baby.
You should know better. Chris Cross is not having anything today. As we stand up, slowly crossed out, we can mix to make you jump, jump. Go back down and make you jump, jump. Oh, Daddy, man, go make you jump, jump. Chris Cross will make you jump, jump. Don't try to compare us to another bad little fad. I'm the Mac and I'm bad. Give you something that you never had. I make you bump, bump, wiggle and shake your rump. Cause I be kicking the flavor that makes you wanna jump. How high, real high, cause I'm just so fly. A young, lovable, huggable type of guy. And everything is to the back with a little slack. Cause inside out is wiggin' and wiggin' and wiggin' and whack. I come stomping with something pumping to keep you jumping. R&B, rapping, bull crap is what I'm dumping. Ain't nothing sucked about Chris Cross, we all act. So when they ask, do they rock? Say believe it. Jump, jump. Come back down and make you jump, jump. I daddy back will make you jump, jump. Chris Cross will make you jump, jump.
Say what? Yeah, girl, you know what's up. Ooh, say what? Ooh, girl, you know what's up. Me and my people be rolling, scheming on you and your homies. The very first day of summer, all grown out in a Hummer. Hit the park and parlay. Hope that you walk this way. If you and your girls wanna ride, play all day, puff on the line. Say what? You know that I like it, baby. Ooh, girl, you know what's up, and you know what I need. Ooh, say what? You know that I'm about it, baby. Ooh, girl, you know what's up.
me you're sorry.
This is how we do it. This is how we do it. La 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 la.
With the guy that keeps mind is also known as a buster. Always talking about things on his broke ass. So, no, I don't want your number. No, I don't wanna give you mine. And no, I don't wanna meet you nowhere. No, don't want none of your time. And no, I don't want no scrub. A scrub is a guy that can't get no love from me. Hanging on the passenger side of his best friend's ride, trying to holler at me. I don't want no scrub. A scrub is a guy that can't get no love from me. Hanging on the passenger side of his best friend's ride, trying to holler at me. Checking me, but his game is kinda weak, and I know that he cannot approach me. 'Cause I'm looking like glass and he's looking like cash. Can't get with a baby that's so. No, I don't want your number. No, I don't wanna give you mine. And no, I don't wanna meet you nowhere. No, don't want none of your time. I don't want no scrub. A scrub is a guy that can't get no love from me. Hanging out the passenger side of his best friend's ride, trying to holler at me. Tell me what you want. Just tell me what you want. 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 Tell me what you want from me. Take a look at what you see. Let me know if this right here something you can have for a year. Tell me what you want from me. Take a look at what you see. Let me know if this right here something you can have for a year.
Now, Mace be the man, wanna see you doing good. I don't wanna get.
Well, some I guess tonight is your night. Madame is turning on.
Reason why I love you, you don't like me 'cause I'm status. I don't wanna see you with a carriage, living average.
DJ Weaver, tell the Mrs. Sena only 21 times a month.
Girl, I wanna give
No
you
more.
you a rabbit.
Only 21 times a month.
That's going out to the household, you know?
That ain't about you.
Tell me what you want from me. Take a look at what you see. Let me know if this right here something you can have for a year. Tell me what you want from me. Take a look at what you see. Let me know if this right here something you can have for Boy, I'ma make you love me, make you want me, and I'ma give you some attention tonight. Now follow my intuitions, what you wishing. See, I'ma keep you up all night for a long time. Start counting away. Wake me up, show me what you got, 'cause I don't want no 1 minute man. Wake me up, show me what you got, 'cause I don't want no 1 minute man. Wake me up, show me what you got, 'cause I don't want no 1 minute man.
Sicker than your average. Papa twist cabbage off instinct. Niggas don't think shit stink. Pink gators, my Detroit players. Tim's for my hooligans in Brooklyn. Dead right, if the head right, Biggie there every night. Papa been smooth since days of under rules. Never lose, never choose to. Bruce, cruise who? Do something to us. Talk to us. Girls want to us, wanna do us, screw us. Who us? Yeah, Papa and Puff. Close like Starsky and Hutch. Stick to clutch. Yeah, I squeeze 3 at your cherry M3. Bang every MC easily. Recently, niggas frontin' ain't saying nothing, so I just speak my peace. Keep my peace. Cubans with the Jesus peace. With my peace. Packing, asking who want it. You got it, nigga flaunt it. That Brooklyn bullshit, we on it.
Can't you see? Sometimes your words just hypnotize me, and I just love your flashy ways. I guess that's why they're broken. You're so fake. Biggie, 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 can't you see? Sometimes your words just hypnotize me, and I just love your flashy ways.
Mother vampires of the season, until blood, blood, blood.
Yo, Dre. Thought I was dead. West Coast. I'm the doctor's advocate. Dre shot you, brought me back from the dead. That's why they call him the doctor. The Mavs gon' drop him, and 50 ain't rockin' with him no more. It's okay, I get it poppin'. Whole club rockin' like a 6'4" Impala. Drink Chris, throw it up, call it hydraulics. Damn, in the cup, call it hypnotic. I bleed Compton, spit crack, it's chronic.
You want your proper pick? Call me. You want to get your kick? Call me. You want the G6? Call me. Me have the remix? Call me. From the other day, like I play some boy I play. Me hear the girls calling, hear the girls bawling, hear the girls crying out. It's a big
I want a dude with the wickedest slang. I need a 1, 2, 3, how a man. I want a dude who would time it to the fan. I got back in time, got his biz like a man. I want a dude with the wickedest slang. I need a 1, 2, 3, how a man. I want a dude who would do me in his van. I got back in time, got his biz like a man.
I'm on the go. I know, you know. God know, I'm on the go. But bad man, I try to stop me though. I know, I'm on the go. Yeah, don't me want coming up off the show. Yeah. I'm so special, so special. That's why I'm strapped with my 45 special. Boy, I bring it together, they want chase like petal. Thank ya. I'm so special, so special. Tell them enough fear, two fierce expression. Guy for no dirty mouth can't chase nor they can't see them shot.
Coulda see them, girl, who a coulda see them. So walk out with your friend. Jump around. Tell her don't pick up. My back. As she a chatting, no she really can't. My back. All them a chat, so one them can't knock your back. Look on the one that keep up like a bad. Her face a brown and her whole body black. The pedicure, but check out the heel back. How we pull up a spot and how we pull up a crack. Fight over man, I know the man no come back. But then the boy you keep that sitting there with fat. Him have to call off your phone, want to lock in on your home.
Wait them man, wanna think me did done. Wait them man, who that a come? Wait them man, wanna think me did done. Me come fit and up, say DJ go and go sit down. Me come fit and up, tell them fi pack up and run. Me come fit and up, DJ go and go sit down. Me come fit and up, tell them fi pack up and run. Now, put up and come off of the right. Me have two stickers on the mic. Admiral, come off of the left before me use the bomber and box it in the depth. He's the grinds man, him a send threat. Me electric chain, me go shock him to death. Wait the man, who that a come? Wait the man, who no think me did done? Wait the man, who that a come? Wait the man, who no think me did done? Enough of them a pose and I say them a done. Only done me know a the one skeng man. That the done man him run the island. Hey foolish DJ, you a look position. Couples now you brief in front of your man. Wait the man, who that a come? Wait the man, who no think me did done? Wait the man, who that a come? Wait the man, who no think me did done? Me come fit and up, say DJ go and go sit down. Me come fit and up, tell them fi pack up and run. Me come fit and up, DJ go and go sit down. Me come fit and up, me no come fi make fun. Me lyrics them a fire like a bullet from a gun. Watch the little boy them a pack up and run. And listen ragamuffin me a chant them down. Tell the whole of them say me just can't done. Wait the man, who that a come? Wait the man, who no think me did done? Wait the man, who that a come? Wait the man, who no think me did done?
No get it when them react, man. Over the bikini girls are gone bad. And you them no get it when them react. Watch it.
Over the dicky. Jackie gets stabbed and get one up with a stick. Bad, look sweet, that nice. But them a guinea god. Now run no risk when it comes to them rod. No them man like come Moses. Rule him rod and girl brush against them match. End up in a body. We not go far, we go know. All of the blessings fall on my yard. Blessings stay for my yard, And like a dad, we go big, we go see, we go feel because the blessings fall on my yard. Blessings fall on my yard, That's why I step my alcohol. I don't wanna reason bad things no more. I don't wanna go back to where I did before. Make nobody stress me, don't disturb me, cha. I sip my alcohol. I don't wanna reason bad things no more. I don't wanna go back to where I did before. Make nobody stress me, don't disturb me, cha.
Can't ball in a life, man. Go on with it.
Yo, Izzy, are you kidding me?
Ghost, yeah. So we are coming with a force, yeah. Blessings we are reap and we coursing on full. Oh, we not rise and boast. Yeah, we give thanks like we need it the most. We have to give thanks like we really supposed to be thankful. Blessings all for my life and my thank God for the journey, the earnings, not just for the plus. Yeah, and gratitude is a must. Yeah, me see blessings fall by my right hand. But I toast for the friends that take off every load. One time kids sit down in a class and we pour them twice and we pour them with one with the road.
Bullet position. I born as a bedroom bully for the girl bikini. I born as a bedroom bully, girl a wind up to me. Built up girl is man a bedroom bully, man a bedroom bully. I born as a bedroom bully for the girl. Hey, wine and cock up.
Big up to you, Christian Davidson and the basic. Danny Cheto, you still on? Love you all.
Foot right there, so lift it up and cock up. Waistline tell time when you tick and tack up. Style in a short, a girl enough you have up. Love how you sexy, you round and fat up. Have your palmy base, girl, the whole place smash up. I born as a bedroom bully for the girl bikini. I born as a bedroom bully, girl a wind up to me. Bully.
This is another Tolio for my man. Make I tell you waiting happen for a bully. But this big party inside my bully. I went there with my best friend Kule. They there with his girlfriend Shile. Ghetto girls then they like Takasufi. So many pretty girls they inside my mule. I just the one that say which can party, everything yakba, everything there. Oh shit, I get many girls with them they come from away. AJ boys then they like to throw away. Almost go babe. We just having fun. We won't carry on. Crazy girls like make this stallion. But my girlfriend they turn me on. That's why I hold on tight. Hold on, yeah. Hold on tight. Hold on, yeah. That's why I hold on tight. Hold on, yeah.
And the boy will love. Not in my eyes, in my mouth, you don't tell her. I ain't telling cause I give you umbrella. I thought we in this together. Give you my necklace, pendant. Give you my last cash, pendant. I show you my best friend. I thought we in this together. Give you my necklace, pendant. Show you my best friend. I give you my last guy, spend everything I do, I under 50, under. Me under be under 50, understand.
Yeah, DJ. DJ Weaver, this about come back to
Last night I dreamt of San Pedro, just like I'd never gone. I knew the song, a young girl with eyes like the desert. It all seems like yesterday, not far away. Tropical, the island breeze, all of nature wild and free. This is where I long to be, La Isla Bonita. And when the song was played, the sun would set so high, ring through my ears and sting my eyes, your Spanish lullaby. I fell in love with San Pedro. Warm wind carried on the sea, he called to me, te dijo te amo. I prayed that the days would last, they went so fast. Tropical, the island breeze, all of nature wild and free. This is where I long to be, La Isla Bonita. And when the sun was played, the sun would set so high, ring through my ears and sting my eyes, your Spanish lullaby. Got your effortlessly, that's the way it was. Happened so naturally, didn't I know it was love? The next thing I got was you holding me close. What was I gonna do? I let myself go. And now we fly through the stars. I hope this night will last forever. I've been waiting for you. It's been so long. I knew just what I would do when I heard your song. Fill my heart with kiss, gave me freedom. You knew I could not resist. I needed someone, and now we're flying through the stars. I hope this night lasts forever. Ain't nobody loves me better. Makes me happy, makes me feel this way. Ain't nobody loves me better.
Somebody left now, you are now. I go.
Hey, DJ Weaver, we out, man. We out. Thank you so much.
Come on.
Let's talk about sex, baby. Let's talk about
We'll end in 8 minutes, huh?
Let's talk about all the good things and the bad things that make me. Let's talk about sex. Let's talk about sex. Let's talk about sex. Let's talk about sex.
Let's talk about sex for now. To the people at home or in the crowd, it keeps coming up anyhow. Don't be coy, avoid, or make void the topic, cause that ain't gonna stop it. Now we talk about sex on the radio and video shows. Many will know anything goes. Let's tell it like it is and how it could be, how it was, and of course how it should be. Those who think it's dirty have a choice. Pick up the needle, press pause, or turn the radio off. Will that stop us, Pen? I doubt. All right then, come on, spin.
Let's talk about sex, baby. Let's talk about you and me. Let's talk about all the good things and the bad things that make me. Let's talk about sex. Let's talk about sex a little bit, baby. Let's talk about sex. Let's talk about sex.
How do rumors get started? It started by the jealous people, and they get mad seeing something they had and somebody else is holding. They tell me that temptation is very hard to resist.
tricks for me. I want a man that means everything he says.
Somebody don't see, you don't see it?
And not
Let
a
go.
boy full of faith.
Are they on
I don't even know why somebody's still here.
Ooh, baby, I'm scared of you. I don't believe in magic. I believe in love everlasting. Can't understand that. Ooh, James was a great magician.
You two should be in bed.
He could crack the lock. Oh, yes, he could. From any position. But my heart is nothing like those locks. And your formula's not my brand of stock. Like Little Red Riding Hood, you're the fox. Oh, and baby, I'm scared of you. I don't believe in magic. I believe in love everlasting. I don't believe in magic. I believe in love everlasting. Don't go pulling no rabbits out your hat. It'll be all out for combat. Baby, now I can't go for that. I can't understand that, baby. No, no. I can't understand that. You ain't no Houdini. Oh, I know I ain't. And I can't understand that, baby.
Oh, like Rudolph Valentino, I can fall down on my knees, pull flowers out my sleeve. And girl, I know you will be pleased. I wonder.
I can't understand that, baby. I can't understand that.
Look, I can pull flowers out my hat, do a disappearing act, come back on you so strong. Girl, I really turn your loving on. I wonder.
I can't understand that, baby. I can't understand that. I need a man.
I'm available.
Mean everything you say. Don't need a boy full of games and tricks every day. I can't understand that, baby. No, no. I can't understand that.
Baby, let me groove ya.
I need a little more.
Baby, let me soothe ya.
Oh, oh, baby, I need a little more.
Baby, let me hold ya.
Oh, oh, baby, I need a little more.
Baby, let me squeeze ya.
Oh, child, I need a little more.
Baby, what you want?
Once again, thank you all. Thanks for listening.
you.
Thanks for hanging and spending time with us. Y'all have a wonderful weekend. Happy Thanksgiving to you all. Let's eat, party, and come back.
You were rolling over, falling on your face. You must be having fun. Walk lightly, take up the time. You best believe this thing is real. Put away that gun. This party's simple. Try to recognize what is in your mind. God help.
Thank you, guys.
Have a good night.
Have a good night.
Sama, you don't download anything where you need for download. I can end the meeting for all, or I'll let you make you do it. Okay, I'm ending for all.